Today I'm going to talk about Tolac and VBAC. Why is it important is that there is a tremendously increasing cesarean section rates. It's alarming worldwide, including India. According to the National Family Health Survey, CS rates have increased from 8.5% in 2005-06 to 21.5% in 2019 to 21. And latest, I don't have the data, it's increased even further. WHO recommends a cesarean rate of 10 to 15% for optimal maternal and neonatal outcomes. Advanced maternal age, higher socioeconomic status, literacy, access to a better health facility, and the private sector have all been responsible for this increase. The rate of primary CS is rising due to IVF pregnancy, older maternal age, cesarean and maternal request, and fear of litigation. This forms a very, very important aspect also. Urgent need to optimize cesarean rates, both by decreasing the rate of primary cesarean section and encouraging mothers with previous cesarean section for a trial of labor after cesarean, which is Tolac. Now, Tolac and VBAC, if you're looking at it, a successful trial of labor after cesarean, Tolac, followed by a VBAC, are two aspects of delivery wanted by every obstetrician in current practice. But the risks associated with unsuccessful VBAC could be considered pretext for malpractice lawsuits. VBAC is associated with lower rates of hemorrhage, thromboembolism, and infection, and a shorter recovery period compared with women who have an elective repeat cesarean section or ERCS. Now, risk management involves 5 simple steps of identifying, analyzing, ranking, treating, and monitoring a specific risk. Now, identifying risk factors, implementation, patient history, which is readily available as early as the first trimester visit. Along with that, a sonographic evaluation of the fetus or the uterus. For example, uterine scar position, thickness, placental position, etc. Now, implementation, you have a prenatal screening and prediction of adverse maternal and neonatal events, patient education, creation of a fully equipped health facility with trained personnel, development of internal and national protocols for Tolac and VBAC, a multidisciplinary team for reducing VBAC-related maternal mortality and fetal morbidity and mortality. Now, favorable factors that offer a high probability greater than 60 to 70% of achieving VBAC. Now, this can be assessed in your antenatal period. One previous cesarean delivery with a low transverse incision, previous vaginal delivery either before or after the cesarean delivery, active labor at 39 weeks of gestation or less, with an expected fetal weight of less than 4 kg and a favorable cervix. Time interval since the last cesarean section has to be greater than 1 year. Absence of serious maternal comorbidities and a health facility with the right equipment and trained personnel. Non-favorable factors are previous with a previous low vertical incision or an unknown type of incision, previous uterine rupture, breach or transverse placenta previa, large baby, maternal obesity, or 2 or more previous cesareans. Now, neonatal outcomes were higher for Tolac than for ERCS. Transient tachypnea of the newborn is more common with ERCS as compared with Tolac. And other rates of suspected and proven neonatal sepsis are higher for Tolac than for ERCS. So this has to be told to the patient also. There is a VBAC predictive score, which is there on the net. All of you can see it, based on maternal age, vaginal birth history, indications for cesarean, cervical effacement, and cervical dilatation at admission. Now, most important is antenatal counseling and consent. All mothers must be counseled in the antenatal period on the risks and benefits of both VBAC and ERCS after a review of previous records and assessment of the integrity of the scar. A patient information leaflet must be provided routinely to the mothers during the counseling session. A VBAC checklist must be used during counseling for a shared decision-making and informed consent. A final decision on the mode of birth should be agreed upon by the mother and the treating obstetrician before the expected or the planned date of delivery. Mothers should be informed that the success rate of planned VBAC is only 72 to 75%. They should not expect a 100% success rate. They should also be informed that the risk of uterine rupture following a planned VBAC with previous one cesarean is approximately 0.5% or 1 in 200. Counseling, women should be informed that the absolute risk of VBAC-related perinatal death is compared to the risk for nulliparous women delivering vaginally. It is not increased. ERCS is associated with a slightly increased risk of intra-abdominal and pelvic adhesion, placenta previa, accreta spectrum, and cesarean scar pregnancy in future pregnancies. So they have to be told that if they are finishing off with this pregnancy, it's okay. But if they're planning another pregnancy, then this has to be kept in mind. The risk of perinatal death with ERCS is very low, but in ERCS performed before 39 weeks, there is a small increase in the risk of neonatal respiratory morbidity. Women should be informed that highest chances of adverse outcomes occurs when Tolac ends in emergency cesarean. Now, benefits of Tolac, maternal benefits are vaginal birth after CS has a shorter hospital stay, faster recovery, avoidance of major surgery-related complications, multiple cesareans in future with resultant complications, increases the likelihood of future vaginal birth, and risk of maternal mortality is reduced compared with ERCS. Neonatal benefits are increased likelihood of early initiation of breastfeeding at birth, exclusive breastfeeding at discharge, and at 6 to 8 weeks postpartum. Risks are maternal risk. There are 25 to 28% chances of emergency cesarean in women undergoing Tolac. Emergency cesarean is associated with a higher morbidity compared to an elective cesarean. Risk of uterine rupture is 0.5%. Risk increases with induction and augmentation of labor. There's a potential trauma to the perineum and the pelvic floor following vaginal birth, as is there in any nulliparous woman. Risk of anal sphincter injury is increased in women having second birth following previous one cesarean compared with nulliparous women. Neonatal risk, increased risk of perinatal mortality, prospective risk of antepartum stillbirth while awaiting spontaneous labor beyond 39 weeks. Recommended time for ERCS is 0.1%, an increased risk of hypoxic ischemic encephalopathy and associated long-term sequelae compared with ERCS. Now, benefits and risks of ERCS. Maternal benefits are lower risk of uterine rupture, convenience of a planned procedure, risk of emergency cesarean is less, lower prevalence of urinary incontinence and pelvic organ prolapse in women who deliver only by CS, and sterilization can be offered in the same sitting. Maternal risks are potential risk in conceiving in future.
We can't see your slide.
No, they can be seen. Who's there? वो अपना network check करे. Dr. Kiran.
Now, yes. No, somebody else also wrote.
Check your own network.
Maternal risks are potential risk in conceiving in future, more likely to have a CS in future pregnancy, increased risk of placenta accreta, maternal morbidity and mortality, and increased risk of maternal mortality compared with VBAC. Induction of labor informed about a 2 to 3-fold increased risk of uterine rupture and around a 1.5-fold increased risk of cesarean delivery in induced and or augmented labor. Mechanical methods of cervical ripening are safer compared to the use of prostaglandins with regards to risk of scar dehiscence or scar rupture. IOL at term with mechanical methods, Foley's catheter, and augmentation with amniotomy shows a good success rate. Induction with prostaglandin analogs or oxytocin increases the risk of rupture by 1.5-fold. Oxytocin dose above 20 milliunits per minute increases the risk of uterine rupture. Misoprostol is contraindicated due to high risk of rupture. Evidence of the use of dinoprostol is not clear. Now, caveats and special circumstances. intrapartum circumstances may result in a patient no longer being a safe candidate for VBAC if there is fetal distress, significant bleeding of uterine origin, new onset of severe abdominal pain disproportionate to labor, inadequate labor progress, and every attempt should be made to allow for patient autonomy in decision making. At every stage, please ensure that the patient is counseled, the relatives are counseled. According to ACOG, consistent with the principle of respect for the patient autonomy, patients should be allowed to accept increased levels of risk. However, patients should be clearly informed of the potential increases in risk and management alternatives. ये ना हो कि patient कहे कि नहीं madam, आप labor should be a normal only. Whereas when you have decided it's going to stop and you're going to do a cesarean. Emergency cesarean, women should be made aware that the greatest risk of adverse outcome occurs in a Tolac failing and resulting in emergency cesarean delivery. Category 1, where there is immediate threat to the life of the woman or the fetus, the decision delivery time should be 30 minutes. Category 2, maternal or fetal compromise, which is not immediately life-threatening, decision delivery time is 75 minutes. Category 3, no maternal or fetal compromise but needs early birth, the decision delivery time is 24 hours. And category 4 is birth time to suit the woman or the healthcare provider. These have to be kept in mind when you're seeing your setup, that you have to have your anesthetist in-house, you should have a pediatrician in-house, all that. Elective repeat cesarean, previous uterine rupture, previous classical cesarean, we've done all this, previous 2 or more cesareans, previous myomectomy, and ERCS should be planned after 39 weeks of gestation. Prophylactic antibiotic prophylaxis should be given, and when there is associated medical and obstetric indications, timing of cesarean must be individualized based on the risks and benefits to the mother and the fetus, as with any elective cesarean you do. Now, this was the FIGO guidelines of how do we go for Tolac and VBAC. I think all of us know this and we followed this. Now, what is important as far as legal aspects are concerned is the consent form. Take the patient's signature or initials on every page of the consent form. Record specifically the name of the doctor or nurse who has obtained the patient's signature. Fill the consent form in legible handwriting. Avoid using abbreviations. Savior for doctors is the consent and documentation. Completion and documentation of a shared decision-making process between the patient and their obstetrical care providers. Chart documentation, an electronic medical record shortcut, or a VBAC consent document that is reviewed and signed during prenatal care. In either case, the risks and benefits of both successful and unsuccessful trial of labor after cesarean should be discussed and the discussion documented. In your OPD summary at that prenatal visit, please document that all this has been discussed in detail. Maintain an open and transparent communication with the patient and her family throughout the process. In all this, communication and documentation is the most important aspect. Now, this is our Apollo informed consent of VBAC. It's a totally descriptive form regarding all the complications, this thing. Plus, we have made a patient information leaflet for vaginal birth after cesarean, which is a 3-page thing, and we hand it over to the patient. This is there in English and in Hindi. And we hand this over to the patient in our last prenatal counseling when we are discussing whether to do a Tolac at all or an ERCS. And we hand it over to the patient, tell them to sign it, read it, understand it, and sign it, and get it with them. And we take a photocopy of this and attach it to our case sheet. Why is documentation important? Courts are not the courts of justice, but courts are the courts of evidence. Courts see only things which are shown to them, nothing else. So hence, your documentation is very, very important.